Um, Imagine breaking your arm. You go to the hospital, you get an X-ray, you see that like jagged white line right on the film,
Mm.
and the doctor just points at it and says, there it is.
Right. It's comforting in a weird way.
Exactly. It's comforting because the problem is visible. It's undeniable.
Yeah.
But what if you were in just excruciating pain and every single scan, every test, every evaluation came back perfectly clear?
Yeah, that's incredibly frustrating.
It is. And for decades, I mean, millions of women with severe chronic pelvic pain have been sitting in these clinical offices describing absolute agony, only to be told that, well, there's no infection, there's no visible trauma. So ultimately, this pain is just like a psychological block, that it is all in their heads.
Which is just a devastating thing to hear, when your body is sending you very real, very physical distress signals.
Right. So today we're taking that invisible pain and we're making it visible. Welcome to today's deep dive. We are jumping into a stack of recent clinical studies from journals like Vulval and Brain, alongside these clinical guidelines on neuropathic pain, to basically look straight down a microscope.
Yeah, we're getting right down to the cellular level today.
We really are. The mission today is to unpack this highly complex, widely misunderstood biological chain reaction. Specifically, how a systemic immune quirk, which is known as chronic systemic mast cell activation syndrome, or MC, how it can fundamentally rewire the nervous system, alter vulval mucosal tissue sensitivity, and severely exacerbate baseline dyspareunia, which is like severe pain during intercourse.
Yeah, I mean, we're looking at a literal turf war happening at the microscopic level in the tissue. The sources we're pulling from today, they prove that this pain isn't some psychological flaw. It is a structural and chemical reality.
Okay, so to understand this turf war, we kind of have to establish who the primary combatant is, right? The sources keep pointing to the mast cell. So what is a mast cell actually doing in the body?
So mast cells are they're ubiquitous immune sentinels. You can think of them as the body's frontline border patrol.
Okay, border patrol.
Right. They are stationed all throughout your connective tissues and mucosa, heavily concentrated in places where your body actually interacts with the outside world. So we are talking about your skin, your respiratory tract, the lining of your gut, and crucially for our deep dive today, the genitourinary tract.
Right, and inside these mast cells are these tiny sacs or granules, right? And they're packed with different inflammatory chemicals. I think most of us know histamine from like allergy commercials, but they hold a whole cocktail of other mediators too, don't they?
Oh, absolutely. Tons of different chemicals. And normally, when a mast cell detects a genuine threat, like a parasite, a dangerous toxin, or, a severe allergen, it bursts open.
Like a little explosion.
Exactly. It degranulates. It dumps all these chemicals into the surrounding tissue to trigger an inflammatory response, recruit other immune cells, and basically start the healing process.
So the normal function is highly protective. Like you want those sentinels there.
You definitely do. But in mast cell activation syndrome, or, MCS, these cells are inappropriately triggered.
They're misfiring.
Yeah, they degranulate and release their chemical payloads constantly, or they do it in response to completely harmless stimuli like mild friction, temperature changes, or even just like stress hormones.
Okay, let me try to unpack this. So normal mast cells are like diligent security guards. They see an actual fire, they pull the alarm, and the sprinklers go off to save the building.
Right, perfect analogy.
But in MCS, it's like the guards are hallucinating threats.
Right.
They're constantly pulling the fire alarm and flooding the building with water when there isn't even a fire.
And the crazy part is that hallucination happens systemically. It affects the entire body, which is why people with MCS often have these bizarre overlapping symptoms.
Like what kind of symptoms?
Well, hives on their skin, sudden severe digestive issues, asthma-like symptoms, and brain fog. All seemingly disconnected, but actually driven by the exact same hyperactive security guards.
Wait, I have to challenge this, though. You just said mast cells are everywhere, right? In our skin, our gut, our respiratory tract.
Yeah, they're all over.
So if someone has systemic MCS, why does the pelvic floor become this hyper-localized ground zero for such severe pain? Like, why aren't we seeing these issues erupting in, I don't know, their elbows or their kneecaps?
It comes down to tissue density and the specific environment of the mucosa.
Okay, density, meaning just more of them?
Yeah, the bladder wall, the bowel, and the vulva are incredibly rich in mucosal mast cells. They just have a naturally higher concentration of these sentinels compared to, your elbow.
Oh, wow. Okay.
So when you have systemic activation, these localized, really densely packed populations are dumping massive amounts of histamine and inflammatory mediators into a very confined, highly sensitive area.
And histamine causes blood vessels to dilate and leak fluid, right?
Mhm. Exactly, which leads directly to tissue swelling, redness, and itching. In the vaginal and vulvar tissue, this persistent, low-grade inflammatory environment drastically worsens vaginitis and pain.
Right. But if the tissue is constantly flooded with histamine, that explains the swelling and the chronic irritation.
Mm.
But swelling doesn't equal agonizing pain from the absolute lightest physical touch.
No, it doesn't.
So how does mere inflammation cross the line into, actual debilitating nerve pain?
Well, that boundary crossing brings us to a specific manifestation called provoked vulvodynia.
Okay, provoked vulvodynia.
Right. It's a localized pain syndrome characterized by severe mechanical allodynia.
And allodynia is when things that shouldn't hurt do hurt, right?
Precisely. Allodynia happens when the sensory system misinterprets normal touch as catastrophic tissue damage. So a normally non-painful stimulus like wearing tight clothing, using a tampon, or attempting intimacy registers in the brain as searing, burning agony.
That sounds horrific.
Mhm.
And for a long time, doctors couldn't see anything wrong with the naked eye, so they just dismissed it.
Which is exactly what the studies aim to correct. The researchers here took vestibular biopsies from women suffering from severe provoked vulvodynia and compared them to healthy controls.
Right, and they use these specialized chemical markers that literally light up nerve fibers under a microscope.
Mm-hmm.
And what they found was massive hyperinnervation.
Yeah, it's wild. The nerve fibers were physically intruding into the outer layer of the skin, the epithelium, to greater than 50% of its depth.
That's, 50%.
Yeah. Imagine a normal smooth sidewalk, and suddenly jagged tree roots are just bursting up through the concrete everywhere. The tissue is literally overgrown with rogue pain-sensing nerve fibers.
Okay, let me ask about the chicken and the egg here.
Mm.
If you look at that overgrown tissue under a microscope, are there just a higher quantity of mast cells hanging out in these painful areas? Or are the mast cells actually doing something differently?
Researchers tested that exact premise, and they found it's not simply a matter of having more mast cells crowded into the area. In fact, sometimes the absolute number of mast cells is completely normal. But when they use specific chemical stains that only highlight the proteins secreted during a mast cell explosion, the painful area is lit up like a Christmas tree.
Meaning the evidence of their weapons being fired was everywhere.
Exactly. The mast cells present in these incredibly tender, painful zones were highly activated. They were actively firing and constantly degranulating, creating a very hostile local environment.
Here is where the microscopic evidence gets really wild to me.
Wow.
We have these angry, constantly firing mast cells, and we have this massive overgrowth of nerve roots in the exact same spot.
Right, they have to be interacting.
Right, they have to be communicating. And the studies map out the exact molecular mechanism driving this disease, and it starts when the mast cells release a chemical called nerve growth factor, or NGF.
Yep. NGF binds directly to receptors on local sensory nerve fibers and essentially commands them to sprout and proliferate.
It's like fertilizer.
Exactly. It signals the nerves to grow rapidly and aggressively into the surrounding tissue.
But tissue isn't just empty space, To give you an image to hold on to for how this works, the sources mention an enzyme called heparinase that the mast cells also dump into the tissue.
Right, a very destructive enzyme.
Yeah, and heparinase breaks down the extracellular matrix, the actual structural connective tissue holding everything together.
Yeah.
So the mast cell is essentially handing the nerve an energy drink, the nerve growth factor, and then using a machete, the heparinase, to just hack a path through the structural tissue so the nerve can grow into places it absolutely shouldn't be.
I love that analogy. And it's a machete that doesn't just stop at clearing a path. Because once those nerves grow, they initiate this devious positive feedback loop.
Oh, no.
Yeah. Those newly sprouted sensory nerves aren't just passive wires waiting to be touched. They actively secrete their own chemicals. They release neuropeptides back into the tissue.
Wait, which binds directly back to the mast cells, causing them to explode all over again.
You got it.
So the mast cell makes the nerve grow, The new nerve secretes chemicals that panic the mast cell releases more NGF to make the nerve grow more. It just feeds on itself endlessly.
It is a totally self-sustaining cycle of neurogenic inflammation. The physiological result of this endless chemical yelling match is that the neuronal firing threshold plummets.
Meaning it takes way less to trigger them.
Exactly. It takes less and less physical stimulation to trigger a severe pain signal. The nerves become so chemically sensitized, so constantly on edge, that the lightest physical touch fires a full-blown emergency distress signal to the brain.
Okay, this is a light bulb moment. Because even if you don't have pelvic pain, anyone who has ever had a nagging, unexplained chronic injury that just won't seem to heal long after the initial trauma, they might actually be experiencing this exact same nerve immune feedback loop in other parts of their body.
Oh, absolutely.
What?
The sentinels and the nerves just get locked in this endless screaming match.
Which forces the entire central nervous system to adapt, right? If your local nerves are constantly screaming at your spinal cord that there is a severe ongoing injury, even when there isn't a visible wound, the spinal cord eventually changes how it operates to handle the load.
Yeah, the sources refer to this as central sensitization.
Central sensitization.
Okay. Researchers actually looked at animal models to understand this transition. They took rats and subjected their vulvar tissue to repeated, localized inflammatory challenges that reliably activated the local mast cells.
So they were trying to see if the chronic pain stayed localized or if it traveled up the chain.
Precisely. And the chronic mast cell activation in the local tissue didn't just stay local. The constant barrage of pain signals actually caused long-term physical adaptations in the spinal cord itself.
Wow.
Specifically in the relay station where sensory signals enter the spine. The spinal cord essentially acts like an overblown audio amplifier. It physically alters its own gene expression to build more pain receptors.
It manufactures more biological hardware dedicated solely to sensing heat and inflammatory pain.
Yes.
And when the spinal cord produces more of these specific channels, the entire central nervous system becomes hypervigilant. The baseline for what registers as pain is fundamentally structurally altered.
Which brings us to perhaps the most crucial piece of the puzzle here, the systemic overlap.
Right. So what does this all mean for a real patient dealing with this?
Well, when you understand that the immune system, the peripheral nerves, and the spinal cord are all physically altering each other, it explains why doctors so often see a specific trifecta of conditions in young women presenting with the severe pelvic pain.
The trifecta. Right, we see MCS, we see Ehlers-Danlos syndrome, or EDS, and we see postural orthostatic tachycardia syndrome, or POTS.
Yep. Those three almost always show up together.
Let's break down the physical mechanics of that trifecta, because on paper, a joint hypermobility disorder, a heart rate issue, and an immune quirk sound totally unrelated. How does EDS, a connective tissue disorder, fit into the machete analogy we used earlier?
Well, people with Ehlers-Danlos syndrome have genetically fragile, faulty collagen. Their connective tissue is already structurally compromised.
Oh, I see where this is going.
Right. So when that mast cell starts swinging its heparinase machete to clear a path for the rogue nerve roots, it meets drastically less resistance than it would in someone with normal collagen.
The structural fragility of EDS makes their mucosal tissues uniquely vulnerable to this abnormal rapid nerve intrusion.
Exactly. The tree roots can burst through the concrete much faster if the concrete is already crumbling.
That makes terrifying sense.
Yeah.
And then we have the third pillar, POTS. That is a form of dysautonomia, meaning there's a malfunction in the autonomic nervous system, the background operating system that regulates automatic functions like your heart rate, digestion, and blood pressure.
Right.
So how does a racing heart connect to overgrown pain nerves in the pelvis?
Through the vagus nerve, which is the massive information highway connecting your brain to your internal organs. Mast cells are heavily congregated around the enteric mucosa in your gut and near major blood vessels, all of which are innervated by the vagus nerve.
Okay.
So when you have systemic mast cell activation, all that dumped histamine and inflammation constantly irritates and inflames the autonomic nervous system.
It's like pouring static onto the radio dial that controls your heart rate and blood pressure.
That's exactly it. It scrambles the signal completely, creating a massive systemic feedback loop. The dysautonomia causes wild, unpredictable swings in blood flow and heart rate.
Which is exhausting for the body.
It is. Those swings put the body into a state of severe physiological stress, and the stress triggers the release of hormones that activate even more mast cells, which dump more histamine, which further irritates the autonomic nervous system.
Wow. And right in the middle of this systemic body-wide storm is the highly sensitive mast cell-dense pelvic floor, just experiencing intense localized nerve overgrowth and mechanical allodynia.
It's a perfect storm.
So if you're listening to this and you have that trifecta, your autonomic nervous system is scrambling your heart rate, your spinal cord is physically building more pain receptors to amplify every signal, and your localized tissues are quite literally full of overgrown nerve roots. Are you just permanently stuck with this pain?
It sounds bleak, I know.
Yeah, I mean, if the architecture of the body has physically changed, can this loop be broken?
The cycle can be targeted, but it requires addressing the root of the communication breakdown. The primary target has to be the mast cell itself.
Okay, start at the source.
Exactly.
Uh,
The clinical guidelines in our sources highlight the use of mast cell stabilizers, specifically medications that alter the cell membrane. They work by blocking calcium from entering the cell, which is the necessary trigger for degranulation.
They essentially put a heavy padlock on the doors of the mast cell so it physically cannot release the histamine, the heparinase, or the nerve growth factor. You take away the energy drink and you confiscate the machete.
Spot on. But there is a sobering biological reality regarding the timeline of these treatments, which was clearly demonstrated in those rat models we talked about.
Okay, the timing.
Timing dictates the outcome. When researchers administered the mast cell stabilizers during the initial inflammatory events, like right when the local activation started, it successfully prevented the chronic pain from ever developing.
Because the nerves never got the signal to grow.
Exactly. But the study showed that giving the exact same stabilizer 60 days later didn't completely relieve the established pain.
Wait, really? Why? If you put the padlock on the mast cell and stop the shouting, shouldn't the pain just turn off immediately?
Because of the structural neuroplasticity we talked about earlier, by the time 60 days had passed in the animal model, the physical architecture of the tissue was completely different.
The nerves had already proliferated.
Yes. The tree roots had already destroyed the sidewalk. Furthermore, the spinal cord had already built all those extra pain amplifiers. The acute mast cell inflammation might be silenced by the medication, but the hyperinnervation remains.
So even if the mast cells go completely quiet, you still have an overgrown forest of pain nerves and a spinal cord that is listening for trouble with a megaphone.
Right.
That implies the structural damage is permanent, which sounds incredibly discouraging for someone who has spent years searching for a diagnosis.
I know, but it shouldn't be seen as hopeless. It highlights why early intervention is so critical, sure, but it does not mean the established pain is untreatable.
Okay, so what do you do?
It just means you have to treat the new reality of the tissue. Clinical management focuses on quieting the ongoing neuroimmune crosstalk. If you aggressively stabilize the mast cells, you stop the positive feedback loop.
You stop the nerves from getting further instructions to grow or fire.
Exactly. But you still have to deal with the nerves that are already there, which is why the sources point to a multimodal approach. You can't just treat the immune system anymore. You have to treat the central nervous system.
Oh, this is where medications aimed specifically at nerve pain, like gabapentinoids, come into play alongside the mast cell stabilizers.
That's right.
And gabapentinoids essentially act like a volume knob at the spinal cord level, right? They bind to calcium channels on the overactive nerves and restrict the release of neurotransmitters, effectively turning down the electrical screaming so the brain stops registering every physical touch as a catastrophic attack.
Exactly. They turn down the volume.
And you combine that with, say, pelvic floor physical therapy to down-regulate the muscular guarding that develops from years of anticipating pain, and you can significantly reclaim your quality of life.
Yes, but stabilizing that foundational immune cell is the required first step to stop the active damage.
Right. Oh, what we've uncovered today is that dyspareunia and severe vulval sensitivity driven by systemic mast cell activation are the result of a very real microscopic turf war.
Yeah, that's the perfect way to summarize it.
Normal immune sentinels get confused by a systemic quirk, act like rogue agents, and start dumping chemicals that literally carve physical paths for new pain nerves to invade the skin. Those new nerves then yell back at the immune cells, creating a vicious, self-sustaining loop of agony that eventually forces your spinal cord to basically build more pain receptors.
It is a profound structural, chemical, and neurological reality. It is a systemic issue manifesting locally, fueled by a microscopic conversation that medicine is really only just beginning to learn how to translate.
And most importantly, for you listening, it proves definitively that if you have been experiencing this, you are not crazy.
Absolutely not.
It is not all in your head, and it is not a psychological failing. The damage is visible under a microscope, residing right in your tissues, your immune system, and your nerve fibers.
And validating that lived experience with hard biological evidence is really the first step toward actual healing.
Which leaves us with a final thought for you to mull over. We've just mapped out how these rogue mast cells can completely rewire the physical nerves in the pelvic floor, right? And even alter gene expression in the spinal cord. But given that these immune sentinels are present in virtually every tissue in the human body, including the lining of the brain and the entire digestive tract, it makes you wonder, how much of our daily, unexplained physical discomfort, our sudden, seemingly random digestive crashes, or even our severe mood swings and cognitive brain fog is actually just a hidden conversation between an overactive immune cell and a frustrated nerve ending?
This is a huge question.
It really is. Maybe that diagnostic X-ray machine we talked about at the beginning isn't broken after all. Maybe, for decades, medicine has just been looking through the wrong lens. Keep questioning, keep learning, and we'll catch you on the next deep dive.